Thank you for joining us. Welcome to the second in our winter webinar series. Today we've got two of the equine radiologists from VetCT, Dr. Lucy Meehan and Dr. Sarah Powell, presenting on imaging the back and pelvis, which modality is best. It certainly looks like it will be a very interesting webinar, and to find out more about Sarah and Lucy, please head to our website where you can also find out more information about the teleradiology service we deliver. So without further ado, I'll pass you over to Lucy Meehan, where she'll start with imaging the back. Should you have any questions during the session, please just head to the Q&A button at the bottom, pop in your question, and we'll have a live session with both Sarah and Lucy at the end. So please enjoy.
Good afternoon, everyone. Thank you for attending this afternoon or morning, depending on where in the world you are. Very lovely to speak to you all. I will just start by going over what we're going to be talking about, and then we can head it on. So I just want to talk to you a little bit about back pain and the different types of back pain that we see. And then we're going to focus on some specific conditions that are fairly common, that we're commonly imaging when we're reporting images of these daily, and then we'll have a little bit of a roundup about what the best imaging modality or how the imaging modalities all interlink together. So if we start by thinking about why we're imaging the back, back pain is a really common clinical condition that we see, and we often do image the back in order to try and work out why we have back pain. Primary back pain is relatively common, and we do see that quite a lot clinically. However, it's always important to bear in mind that a lot of the time horses can have back pain for other reasons other than primary back pathology: poorly fitting saddles, poorly balanced riders, hind limb lameness, forelimb lameness. These can all contribute to causing tension or palpable pain in the apaxillary musculature of the back. So it's very important to remember these things, and also to remember that any low-grade back pains can be exacerbated by other problems. So it's really important when we're thinking about back pain that we don't just look at the back in isolation, and we think about the horse as a whole. So what's the most common back condition that we see? Certainly impinging dorsal spinous processes or kissing spine is something that we see very, very often in clinical practice. We mostly identify this radiographically. You can see at the bottom here the high power generator setup that we had at one of the clinics I worked at, but you can actually acquire these images relatively easily with a portable generator, and certainly it's something that we frequently get images to report of lateral thoracic spinous processes. It is most commonly the thoracic region that's affected, so some sources say between T12 and T18, some sources say T14 to L2, but usually it's that sort of mid to caudal section of the back. There is some evidence that we see impinging dorsal spinous processes in clinically normal horses. So how do we assess whether or not these radiographs are significant? Now, I think if we were presented with the image on the right here, we'd all agree that this is probably a significant change. We've got 1, 2, 3, 4, 5, probably 6 dorsal spinous processes that seem to all be in one mass. We've got a little bit of overriding here, and we've got overriding here as well. And we've got almost ankylosis here of these two spinous processes. So I think we'd all agree that this one is pretty significant. But how do we work out the more subtle ones and which ones are significant and which ones aren't? And this can be really, really important, certainly in the context of pre-purchase examination. So as I've said, we do see these in normal horses. The important thing to note is that head position has been shown to affect the position of dorsal spinous processes or spinous processes radiographically. So these two x-rays are of the same horse. This was the x-ray that we took where we diagnosed that this horse had probably significant impinging spinous processes. So we've got probably 4, 5 spaces affected. We've got some sclerosis and we've got some lucency here within the spinous processes. So we were pretty confident this horse was blocked as well, and the horse improved under saddle following no diagnostic analgesia. We were pretty confident this was a problem, so we went ahead and prepped the horse for surgery. The horse was more sedated at the time we prepped him for surgery, and his head was lower. And you can see there's a fairly significant difference in the spacing between the spinous processes here. So that's just a cautionary tale that if we are assessing these horses for impinging spinous processes, that their movement of their head or their head position when the radiographs are taken can affect the position of the spinous processes. We tend to take them in the clinic with the standardized head position. So we have the head on a headstand and the nose level with the point of the shoulder. So at least we know that when we take repeated radiographs, that those should be comparable. The reason I wanted to highlight this was certainly in the context of pre-purchase examinations, we're seeing increasing numbers of spinous process radiographs during pre-purchase examinations. And I think it's something we have to be very careful not to under or over interpret, depending on where the head position of the horse is, again, which is why we've decided to standardize this in the clinic. If we're trying to assess what's significant, there is actually a published grading system which has 7 grades, and that grades individual spinous processes, but actually more importantly sums the score to give an overall grade for the back. So if we think about what the grading system might include, well, what it looks at is the space between the spinous processes. So theoretically, there should be a 4 millimeter space between the spinous processes. That is what is classed as normal, published as normal. Narrowing of that would be reducing to 2 or less than 2 millimeters. Sclerosis, so we often see sclerosis in the cranial and caudal aspects of the opposing spinous processes. So that can be graded mild, moderate, or severe. And the presence of lucencies within the cranial or caudal border. So if we just go back to this slide for a second and we look at these spinous processes here, you can see we've got a sclerotic border here and a mild sclerotic border here. And then we've got these lucent regions within the spinous processes opposing each other. That to me is a relatively significant, and that to me would be a moderate grade of spinous process. The other change that we look for is whether or not these are touching or overriding. So touching, so impinging to me is when the spinous processes are touching each other directly. When they are overriding, so the cranial border of one overlaps the caudal border of the other, I would call that an overriding spinous process. So when is the change significant? Well, what the grading system does is it grades it from 0 to 7. I don't tend to use the grading system. I personally grade them mild, moderate, or severe. But what the grading system showed was that the higher the overall score, so if the sum of the number of effector spaces is, the more likely it is that the changes are clinically significant. So I obviously look at each individual space, but also look at how many spaces are affected. So if I had multiple moderately affected spaces, as we had in the case in the previous slide, I would call that significant. And if I had one particularly severely affected space, I would probably call that significant. The images on the right, this top image is what I would class as a normal back. So we've got a nice space between each spinous process here, here, and here. The spinous processes don't have any apparent sclerosis or any apparent lucencies within them. So I think that's a pretty normal back. This one at the bottom is a little bit more challenging. So this has one space, maybe 2, if we're being harsh, we would possibly interpret that one as slightly narrow, but one space where the interspinous space is fairly narrow. It measured about 1 millimeter. We've got possible modeling of the caudal aspect of this articular process, spinous process, and flattening of the cranial aspect of the opposing spinous process. So the discussion is that a significant change or not? And when we're presented with these in the context of a pre-purchase examination, I think that makes this even more contentious, really. I will say that I think that this is possibly an incidental finding in the absence of any other evidence of back pain. However, I would say that this may progress with time to being a clinically significant lesion. Other ways that we can assess whether or not these are significant, well, we'll come on to scintigraphy in a moment and we'll discuss whether or not that will help us. So just some more examples of moderately affected back. So I think this one has 1 I suspect that this is a narrowed space here. We've got sclerosis and we've got some areas of lucency, and I would possibly suspect that this one is as well. So again, I would probably be borderline about whether or not those changes are significant, and possibly there's one here at T18L1. I think this horse is what I would determine as definitely significant. We've got overriding here and here. We've got lucency within at least 3, if not 4 spinous processes, and moderate amounts of sclerosis. So I'd be fairly confident at saying this one was a significantly affected horse. So with these borderline cases, oftentimes we will do scintigraphy, and we'll do this to assess the activity or the level of bone turnover of the impinging spinous processes detected radiographically. The caveat is, as with everything, that increased radiopharmaceutical uptake can be seen in asymptomatic horses. There is, again, a described grading system for this, and the subjective grading system is mild, moderate, or severe. And there was a couple of studies back in the mid-2000s that looked at this, and they found that the intra-operator agreement was reasonable. So I would usually agree with myself. If I called something mild on one study, I'd probably call the same study mild 2 weeks later. But what they found with the subjective evaluation was that between operators, agreement can be poor. And we see this in the clinic all the time. I'll look at a bone scan and think, oh, well, maybe somebody else will look at it, come along and go, well, I think this horse has significant uptake. And it does, it is in the eye of the beholder sometimes. Interestingly, there was a more recent study out of a German group who looked at whether or not grayscale assessment was superior to colour assessment, and they found that grayscale assessment led to better agreement, but not complete agreement. This horse on the right is a horse that has, I think we'll agree, fairly markedly abnormal spinous processes and did have clinical evidence of back pain. He has got some moderate, mild to moderate, probably moderate uptake in the spinous processes on the bone scan. I always look at this image and I'm very surprised he hasn't got more going on the bone scan, but that's just to illustrate that these things, the radiographic and the scintigraphic grades can differ. However, there is usually a significant association between the radiographic and the scintigraphic grades, and there is a significant association between horses that have a moderate or severe grading and have clinical evidence of thoracolumbar pain. Going back to our inter and intra-operator agreement, there was a study recently that looked at using a semi-quantitative method to assess the scintigrams rather than just using the objective method of judging by eye, and that showed that there was higher inter and intra-operator agreement when you actually physically measure the number of counts per pixel rather than just saying, oh, looks mild, looks moderate. The caveat to doing that, although it is a more scientific method of assessing these, it is actually relatively tricky to do after acquisition or away from the point of acquisition. Most scintigraphy systems have bespoke software that is specific to them, and any sort of post-processing manipulation has to be done with that software, which makes it more difficult to do that in a teleradiology situation. So overall, radiography is useful to tell us whether or not there are impinging spinous processes. Scintigraphy is fairly useful to tell us whether or not there's osseous activity associated with that, which can then tell us whether or not these things are clinically significant. But both of them have their downsides. Increased radiopharmaceutical uptake has been reported in normal horses. Radiographic change has been reported in normal horses. So I think both of them are very, very useful to help us put pieces of the jigsaw puzzle together, but we do need clinical correlation to assess whether or not these kissing spines are significant. I like to block them, so I'll often block them under saddle. I think obviously palpation and response to back flexion is also an important thing to take into account. So kissing spines are the most common thing that we talk about, but there are other things that we do see in the back. So the articular process joints are very small, low motion joints between the vertebral bodies. So we can see these joints here, so they're all the way along. In the thoracic and lumbar vertebral column, they're much smaller than they are in the neck, and they're much, much lower motion. But we do know that osteoarthropathy of these joints can be a source of pain. Because they are so small and they are usually buried pretty deep particularly beneath a fairly major muscle mass along the back, they can be really quite challenging to assess. The other nice thing that they do is they change shape from cranial to caudal, which makes sense if you think about the biomechanics and the way the back bends, but it does make it a little bit more difficult to compare one joint with the next joint because they're changing shape all the way along. Sorry, I should say that picture is from a very nice study from Denoir's group over in France. It's a very nice dissection of the articular process joints. So how do we assess these in the live horse? So we do often radiograph these. Now, I've put a big caveat saying that radiographic assessment is challenging. This is not one that you can get in the field with your portable generator. This is the setup at one of the clinics that I've worked in to get these oblique views. So we do a ventral 20 degrees lateral 20 degrees ventral, dorsolateral oblique. We're assessing the row of articular process joints furthest from the plate when we do this, and we are projecting those dorsally. We can't go the other way because there's just too much horse to go through. So this is the only way we can do it with the least muscle mass to pass through. Obviously, we have to acquire these from both sides, and it highlights the side furthest from the plate. This is because the ribs become superimposed over the articular process joints if we try and take lateral views. We do tend to take lateral views for lumbar articular process joints simply because we haven't got the ribs getting in the way. So just to illustrate the point, we've got a lateral view here at the top. These are our spinous processes, vertebral bodies, and our articular process joints or facet joints are tucked in here nicely, directly under where the rib is. If we come same horse, if we do an oblique view, so this is the ribs closest to the plate, the ribs furthest away. So these are the ribs furthest away that are projected dorsally, the ribs closest to the plate projected ventrally. And what we're looking at are these tiny sort of backward L-shaped articulations here, just at the the dorsocranial aspect of the vertebral bodies. Still got a slight limitation in that our diaphragm cuts right across the radiograph, so we're usually missing the T17-18 and often T18-L1 articular process joint. This is a lumbar lateral view, so we've got our lumbar spinous processes here, and these are our lumbar articular process joints here, and the vertebral bodies just down there. Slight caveat that this was a very small, thin pony, so we've got beautiful definition. Unfortunately, in your average warm blood, you're not going to get this beautiful view, and it looks a bit more like a snowstorm. So what do we see when we're looking at the articular process joints? Well, we commonly see osteoarthritis of the articular process joints, and when we say osteoarthritis, what we're looking for is modeling of the dorsal aspect of this joint here, sclerosis of the joint space, and very occasionally you will see lucencies either side of the joint as well, but that tends to be more severely affected joint spaces. There's a really lovely study out of the Animal Health Trust in 2009 that looked at horses with back pain and concurrent pathologies, and they found that horses that had both impinging dorsal spinous processes and articular process joint osteoarthritis are significantly more likely to have clinically evident thoracolumbar pain than horses that didn't have both of those things and didn't have them concurrently. Osteoarthritis of the articular process joints was identified in about 12% of horses in that study. Now they looked at over 600 horses. Now I don't routinely perform obliques of the back. Maybe I should in every case of back pain that I see. And I wonder how many of these horses with back pain I'm missing these articular process joint arthropathies. Certainly, I'm doing them increasingly again now, and we are finding horses with significant changes in these joints. The arthritis is most often located at T15, 16 and T16, 17. I do wonder how far back, so T17, 18, how many T17, 18s are affected. The problem we have is that we can't see that often because of superimposition of the diaphragm. So we don't always manage to get that far back. How do we assess those, and how do we assess whether or not they're significant? Well, we can do scintigraphy on these animals. So When we're looking at the articular process joint scintigraphically, we're doing an lateral oblique view. And this is a horse that has obviously impinging dorsal spinous processes. These are the vertebral bodies. So this line of increased radiopharmaceutical uptake here is the vertebral body. And this line here is the articular process joints. This horse has normal articular process joints. This degree of uptake is entirely normal in the caudal thoracic region, caudal to mid-thoracic region. And we get slightly more uptake the more causally we go. This is a horse that has significant osteoarthritis of the articular process joints. So we can see again, we've got our ventralmost row is our vertebral bodies. The very slightly dorsal to that is our articular process joints. And you can see at T17, 18, we've got fairly significant region of increased radiopharmaceutical uptake. And then we've got two regions of impinging dorsal spinous processes as well. So what the study that looked at scintigraphy told us was that moderate or intense radiopharmaceutical uptake in the articular process joint region was likely to be seen in horses with significant radiographic abnormalities. Only 60% of horses with radiographic evidence of abnormalities had increased radiopharmaceutical uptake, and the ones that were less likely to have increased radiopharmaceutical uptake were the ones with a milder grade of osteoarthritis on radiographs. And I think this is interesting, because I do wonder how many of these we slightly overlook, because we have this normal pattern of increased uptake when we are that is expected within the articular process joints. So I think it's a useful thing to add to our arsenal to do the scintigraphy of these, and it's a useful thing to have the radiographs, but I think sometimes they don't quite correlate as well as we would like. The other thing that we can do is ultrasound these. So this is really, really useful to assess the dorsal aspect of the joint. We can't assess the ventral aspect, but we can assess the dorsal aspect. And we do this you can do it in a thin-skinned horse with a fine hair coat. You don't even have to clip. The transducer is placed just lateral to midline in a transverse plane. It does really have to be a curvilinear transducer. You don't get enough depth of penetration with a linear transducer. And I would always compare left and right articular process joints at each level. There is a really lovely review article that's just been released ahead of print in Equine Veterinary Education, which is where I borrowed the dissection images from, and also it has some absolutely beautiful anatomical descriptions and some absolutely beautiful ultrasound images showing you what you're looking at this level. One of the main reasons for ultrasounding these joints is actually to then be able to do ultrasound guided medication. It's a very reliable technique, it's very repeatable, and actually it's been shown to be fairly easy to do for most practitioners. So what we're looking at when we look at our articular process joints, well, so this is a genuine clinical case. This is a horse that had back pain. This is at the level of L2, L3, and the lateral is to the outside of the image and medial is to the inside of the image. So the first line that we're going to look at is our spinous process. So you see the spinous process going from ventral to dorsal just here as a bright white line. The joint space is here, so it's this interruption just here. So you see this horizontal white line and then a drop off, and you just see the two lips of the joint space here and here. This is perfectly normal. There's often a slight lip here. There's often a slight, it's called a miliary process. You often get a slight spur on the edge of the articulation, and it's perfectly normal. And then we have our transverse process here horizontally. So this is a really, this is a normal horse. It's a very easy technique to do. You just go from cranial to caudal, looking for these, I call them chairs when I'm teaching the interns how to do this, looking for these chair structures and then assessing the margins of that. I like to do them this way. So I like to do the left and then go over and do the right of the same location and compare them in real time. I'm quite sure I have to stand on a stool next to the horse to do it, but taller people than me are able to do it just from one side of the horse. So what are we looking for? We're looking for asymmetry, essentially. So these beautiful images are borrowed from the Denoir paper again. So we're looking for asymmetry between the medial and lateral sorry, the left and the right articular processes. And we're looking to see if we've got any, so you can see this side is much larger than the other side. And you can see we've got some irregular new bone formation, which is more than we would expect from the normal lipping. So those are the sorts of things that we're looking for. And I like to go back and correlate these now back to our radiographs and back to my scintigraphy and just check that I've got the whole picture. The last sort of main osseous change that we see in the back is spondylosis. It's a fairly uncommon finding. So if you think about dogs and cats, we see it all the time. In horses, it's very uncommon, and we're not really quite sure what it means. So we found it in 4% of horses that had clinical evidence of back pain in one of the larger studies. But most of those horses had something else going on as well. So it was difficult to just single out the actual significance of spondylosis. We were seeing various grades. So from this sort of tiny little, possibly incidental spur here, to these almost pseudo articulations down here. And then you see this full bridging type lesion as well. Interestingly, these are the ones that are most active on scintigraphy, but the bone activity doesn't always correlate to pain. I think the most that we can say about these lesions is that they may contribute to back pain, but they're often present with so many other lesions, it can be quite difficult to just assess their significance in full. Just a quick whiz through other less common osseous injuries. We do occasionally see stress fractures. They're most common in racehorses. There's a really nice study that looks at the post-mortem appearance. It can be quite difficult region to image because they're often in the lumbar region. We usually do scintigraphy and there's limited usefulness of radiographic assessment. Finally, soft tissue injuries. Supraspinous ligament desmopathy is reported, and I do ultrasound a reasonable number of these. I find them quite difficult to judge because they're very, very variable anyway, ultrasonographically. And it can be difficult to assess the significance of any changes that you see. I find this most useful when I've got a focal region of pain, when I'm palpating the back, I ultrasound it and I see a lucency, hypoechogenic region there. I don't find it too useful if I'm just seeing lots of vague hypoechogenicities that are not very much else to go with it. Muscle pain, well, we often see spasm and tension in the apaxial musculature is secondary to other issues such as hind limb lameness, other back pain, other causes of back pain. I think it's really difficult to give this a definite, to diagnose this definitively from imaging. I think it's much more of a clinical diagnosis. So in summary, I hope you've taken away that it's more than just kissing spines that can cause back pain. It's more than just kissing spines that we can image. We do need to use a multimodal approach. Certainly, more oblique articular process joint radiographs are required because I think we do miss a number of horses that have this if we don't radiograph that area. Scintigraphic assessment is useful, but it's not the only thing that can give us answers, and certainly sometimes it can confuse us. And ultrasonography is really very easy. Most people have got an ultrasound machine in their car, and it's worth having a try, popping that on and just getting used to what things look like, so then you notice something that might be abnormal. Correlation with clinical presentation and diagnostic analgesia is always required with these things. Certainly, I would be very reluctant to recommend surgery on a horse that had radiographic evidence of dorsal spinous process impingement, but nothing else. The ultimate would be if we could stick these horses through a CT scanner or an MRI scanner and actually look at the cross-sectional, what's actually going on without the superimposition. Unfortunately, that's not possible at the moment, but if people carry on getting fatter, we might get bigger CT scanners, which might then let us look at these things in more detail. So I'm going to leave it there for now. If you've got any questions, please put them in the comments box, and I will hand you over to Sarah for a whistle-stop tour around the pelvis.
Thanks, Lucy. So I'm just going to share my screen a second and get us started. So thank you for everyone for attending today. It's really nice to connect with so many of you. We don't get the chance too often. I'm going to carry on where Lucy has left off and give you a whistle-stop tour through the pelvis. We're going to talk about the imaging options that we have available to us, And conditions-wise, I'm going to stick predominantly to stress and traumatic fractures, and then the lumbosacral junction and the sacroiliac joint region, because they're really the most sort of prevalent conditions that we're seeing. So available techniques, well, obviously radiography started us off in the sort of early 70s, and fair to say that ultrasonography and gamma scintigraphy have taken over, certainly latterly, from radiography. And computed tomography, we will talk about a little bit in this talk, but at the moment, because of the sort of technical challenges, it's sometimes quite tricky to do these in clinical cases. So, but lots of useful information from post-mortem studies. So radiography, the standing sort of VD technique was described in the 70s, and then the GA VD technique in the 70s, and then the standing VD technique in the early 90s was described. But latterly, in the sort of mid-noughties, the lateral oblique view of the pelvis was described, which again, radiography, it is challenging in all patients, even rather smaller horses, and usually requires a referral to a hospital setting because of the generator requirements. The risk of GA radiography is high, particularly when we're thinking about horses with suspect fractures, and so it's sort of gone out of fashion quite significantly. Standing techniques, they are useful in smaller individuals, and for more sort of superficial injuries such as tubercoxar fractures and tuberosseous fractures, less so perhaps certainly for the ilium, and the overlying soft tissue mass is just too great really for sort of comprehensive assessment. It's certainly still useful where scintigraphy is not available and ultrasound is perhaps inconclusive, but certainly less likely to be carried out in most settings than ultrasonography and bone scanning. So indications for X-raying the pelvis, well, moderate, they're all sort of indications for all of these techniques are relatively similar, but moderate to severe hind limb lameness, non-specific findings, clean distal limb, severity of the lameness may sort of present any hind limb diagnostic analgesia, so you may go straight to imaging. Muscle or pelvic asymmetry, and in the case of where fracture pathology is suspected, if crepitus is detected, or sort of swelling of the pelvic region, commonly sort of coxofemoral joint region, or tuberosseous or tubercoxar fractures. I just wanted to say about the ventrodorsal technique. This is from the short communication in EBJ from the early 90s when it was first described, and then the lateral sort of 30-degree dorsal lateral ventral oblique view has taken over from that. This standing view, it's very important to sort of sedate the horse well and evacuate the rectum so that you've got good contrast. And you vertically position the plate on the area of interest, so you're shooting sort of through quite a lot of muscle mass. And these are images from that paper. So you've got a sort of standard image at the top there, and then the bottom is just with the overlay of the anatomy, so that you can see the sort of area of the pelvis that you can image using this technique. So it's really rather restricted to the sort of acetabular coxofemoral joint region, not really anything more cranial in the sort of mid ilial shaft, and the sort of cranial aspect of the ischium. So fairly restricted amount of anatomy. In clinical practice, I've always used a sort of modified ventrodorsal technique where I do a sort of ventromedial dorsal lateral approach. The blue square on the plate on the slide is to indicate where the plate is located, and then you sort of shoot through from the opposite side, and you can actually do this. It depends on the patient a little bit, with the affected limb raised so that you get a little bit more sort of opening up of the two limbs, which gives you better access. And on the right hand side here, this is an image of taken in that way. This horse had recently had its coxofemoral joint blocked, so there's some gas in the joint, which sort of quite nicely delineates the margins. But that's the view I've most frequently used, and I have found it a bit more useful than the standing lateral oblique view. There's other views for different parts of the pelvis, so the tubercoxar view, which is relatively easy to carry out. sort of 50-degree dorsomedial ventrolateral view, and just it's fairly important to say that often they are weight bearing on the affected limb, because this will sort of push the affected tubercoxa proximally just to sort of increase your ability to sort of skyline that area there. So if you can get the horse to do that, then that's the best way. Ultrastenography, one of the most popular and quick and easy ways of assessing the pelvis. I say easy in inverted commas, it can take quite some time to do it, and there's obviously complex anatomy in there, but it's certainly the most commonly used modality just because of ease of access to it. There's no need to transport the horse to the referral facility. Almost all of the more recent ultrasound machines will do a really fine job horse side on the yard. So that's obviously a really useful point if you're thinking about a horse that might have a fracture. So excellent for surface detail of the bone, and obviously there's no radiation safety implications, which is not the same for the other modalities that we've been speaking about. Indications are similar, so similar to the other things, so moderate to severe hind limb lameness. Again, you might not be able to block these horses, so you might go straight to ultrasound if the horse is very lame. You might see muscle asymmetry, crepitus swelling, or in a sort of more general sort of sports horse workup, if you have a positive block to the lumbosacral or sacroiliac joint region, then you may go straight to ultrasound at that point. And commonly also, if you have a positive bone scan results, if you have some increased uptake in an area of the pelvis, then the most likely thing you're going to do the following day is to do an ultrasound scan to try and evaluate what that uptake means. So most useful for sort of stress fractures, iliac wing and the shaft, traumatic fractures of the pelvis, also extremely useful for those. In degenerative conditions such as the lumbosacral intertransverse joints and sacroiliac disease, and the dorsal sacroiliac ligaments, which are nice and superficial, so that you can get some good images of those. It's a really very dynamic process. So it's one of those things where I often see people sort of scanning away and trying to get that one perfect image, and just saving, hundreds of images of the pelvis. But I tend not to take that approach. It's much preferable really to just concentrate on making sure that you evaluate the whole of the pelvis. So spending lots of time looking at the cranial caudal margins of the iliac wing, not just trying to get that one nice curved image of what looks like a nice normal image. So take your time. It's, as I said, it's very dynamic. You really need a very sort of methodical, systematic approach. Left to right comparison is essential because of the range of normals that you have, and it's impossible to do it without having a really good mental image of what the pelvis looks like. So either carry one in your head or have a specimen alongside so that you can check what you're seeing and make sure that you don't lose your landmarks if you're relatively inexperienced. External transcutaneous and per-rectal examinations are necessary for thorough assessment, though they might not be indicated in every case. And I would always encourage people to use stocks if you're per-rectum scanning. I've just had too many colleagues over the years that have been injured, sort of being a hero and doing it in the stable. I have done that myself, but I certainly wouldn't do it now. So it's been a little bit difficult to get out and about recently. So if we have got so many students or people sort of in the early stages of their imaging careers, then there are lots of good online resources that will talk you through, a thorough sort of transcutaneous and per rectum ultrasound scan. So ideally you need a sort of mentor in a clinic that's going to help you and talk you through it. But if you haven't got access to that, then there are some really good online resources which will certainly give you a good start. I just want to spend a couple of slides on the technique of ultrasound, the per rectum examination of the lumbosacral junction and the sacroiliac joints, just to show you the sort of location of the probe and how you're going to approach doing this. And we'll talk a little bit later about abnormalities. So the lumbosacral junction between the 6th lumbar vertebrae and the 1st sacral vertebrae. And so per rectum scanning, obviously probe orientated dorsally. and it's relatively easy to find the lumbosacral junction with the disc material in between, and that's a really good landmark. So whenever I'm scanning the pelvis, that's my go-to landmark. If ever you get lost, go straight back to your lumbosacral disc, and that was a very obvious structure, and that will help you sort of locate where you are geographically. Then we go to sort of scanning off each lateral side to look at the intertransverse joints, but you can see the sort of relatively restricted area that we're going to be able to look at. So we can't really get much further forward than this on the ultrasound. Sometimes you can get, depends a bit how long your arms are, but sometimes you can get L5, L4, L5, L5, L6. But really this is, certainly for me, sometimes I struggle to get more cranial in this. The intertransverse joints are the two sort of joints, again, between the lateral transverse processes of the 6 lumbar vertebrae and the wing of the sacrum. These joints are part of the lumbosacral junction, so we should make sure that we look at them, don't just focus too much on the lumbosacral disc space. And so this is scanning. So this is the lumbosacral disc here, and we're coming off to the lateral side. You can see the intertransverse joint space here, the nerve root fossa and S1 nerve root was just there. There's a nerve root exiting there. So you can see you're just sort of moving sort of 5 or 6 centimeters off to the side, and then you can easily image these joints and reasonably comprehensively. The sacroiliac joint, we're only really able per rectum to ultrasound the most caudal aspect of the joint, so almost all of this is invisible to us. So to locate the sacroiliac joint, we just find the lumbosacral disc, move 1 space caudally and then off to the side, and then you'll find the sacrum here, and it's just a very tiny little joint space in most normal horses, and the ilium there. So it's difficult. You need to make sure that you increase your depth, because this is considerably deeper than the intertransverse joint, but it's there. So if we just go back to the video, so at the disc here, we're deeper here, move back 1 space off to the side, a little bit too far back, it's here somewhere. So here's the sacroiliac joint here, relatively normal looking joint space here. So you just have to come caudally and then off to the side, and it should be there. Scintigraphy, obviously excellent for stress and traumatic bone injuries. That's what it's it's extremely useful in those conditions. It allows a thorough assessment of the whole pelvis and other areas of similar presentation. So for example, if you've got a horse with a sort of poor hind limb action, or if you are worried about multi-site lameness, then this will allow you to scan the pelvis, but then also check out the distal limbs for common concurrent pathologies like lower hock joint pain or upper suspensory pain and these sorts of things. Poor soft tissue injury detection, obviously, and it's certainly less useful in chronic low-grade lameness, certainly in older horses or those that are out of work. And of course, it requires a referral and overnight stay, so it's not quite as accessible. Again, indications, so suspected fracture, you may go straight for a bone scan if it seems safe to move the horse. Hind limb lameness not localized by the distal limbs or poor performance. Sacroiliac joint pathology, so very commonly used in poor performance examinations of sports horses to detect any pathology in the SIJ region. Certainly if you found something ultrasonographically and you want to try and assess the relevance of ultrasound findings. And as part of a sort of wider poor performance workup, so obviously the types of cases that Lucy was presenting earlier, in those cases you would of course also routinely scan through the back and pelvis to make sure that there's nothing additionally that we need to know about. So scintigraphic views, it's really important to maximize your chance of detecting something by making sure that you use a complete set of images. So the dorsal pelvis and oblique ilial wing views. So dorsal pelvis primarily for your SIJ regions, that the oblique views are somewhat less useful for sacroiliac joint injuries, but certainly very useful for stress injuries. Coxofemoral joint laterals and the caudal pelvic, dorsal pelvic view, really this view is extremely useful to look at the acetabular regions as well. On the lateral views, you're only sort of getting the lateral aspect of the proximal femur, whereas on the caudal dorsal view, you're separating the tubercles of the femur from the acetabular region. So that's a really useful view to do. And then essential if you're interested in the coxofemoral joint or the pubis is to do these oblique hip views that I don't see many practices doing these, but they really are part of a normal workup of a pelvis. You will miss a considerable amount of things if you don't include these. And this is a shot that we do sometimes. It's called the rocket shot, but I don't think that's its official name. But basically, it's a sort of oblique view of the pelvis with the camera in a longitudinal plane. So you're missing out the tubercoxy, so it's not, and the tubericium. So it does miss out some of the pelvis, but it gives a lovely view of the whole of the iliac shaft and the acetabular region. So it's a really useful view. So just to run through some of the views, I think really I've just spoken mostly about why we use these views in the recent slide. So important to mask out anything that's obviously causing increased uptake but not of any clinical use, so that the dorsal spines of the sacrum are obviously rather warm, and if you have some bladder uptake then obviously mask out that, and then that will increase your count number in the areas that you're interested. This is a slide just to illustrate the oblique view of the hip. I've got a very old, this is our old gamma camera, the old camera when I first started at Rossdale's in the many years ago. So this is a poor quality image, I'm afraid, but this is the oblique view, so sort of 45-degree angle, and almost sort of perpendicular to the skin on the back on the pelvis at that level. But a really, really very useful shot. And yes, masking of images. So this is a dorsal view of the pelvis. And on the original image, you can perhaps see a little bit of something in the coxofemoral joint region here. But when you mask out the tuber sacrale and the sacrum, you get a little bit more impression that that coxofemoral joint has got increased uptake compared to the contralateral limb. Fair to say that the images are very system dependent and to some degree site dependent as well. And because of the complex way of sort of working up, of sort of preparing these animals for the scan, there are many variables that can go wrong at any stage. The older detector heads had a smaller field of view. So on the dorsal pelvis here, you're missing off the tubercoxy. This is a 60 centimetre field of view with fairly old motion correction software, which sort of summated the images, which is a sort of more old-fashioned way to do it. This is an image from the MI Syntron with a 90 centimetre field of view, so you can see you've really increased the amount of the pelvis that you can get in the image, and paralyzer software, which is a slightly different technique for motion correction, and which gives you a much sharper image. And if you really want to get into the nitty-gritty of sort of diagnosing more sort of subtle and strange, wild and wonderful conditions, then it is this type of quality image that you will need. You have to accept a degree of sort of reduced diagnostic potential if the scanner type that you have is producing images of that type. So the bladder is often a really complicating factor. Obviously, there are ways that you prepare the horse for the scan, which can help, such as giving diuretics after your injection to encourage the horse to urinate. If you do get this sort of uptake from the bladder, so you get this on the first left ilium oblique view, there's a hot spot over the left iliac wing towards the tubercoxer, and then that sort of miraculously disappears on the dorsal view, and then on the right ilium you can see that it's now transposed over the sort of axial aspect of the right ilium, so you know it's the bladder because it's moving around, but it does complicate matters. So masking can help, but there's no substitute really for making sure that the bladder is not a problem, i.e. prepping the horse well, taking the horse out and allowing it to urinate, or in really important, you know, if you have to do it, then you can catheterize the horse depending on the local rules at the practice. CT, I won't speak about this too much, but obviously requires a referral and GA in all instances, I think. It's technically challenging whatever the size of the patient. There are risk implications if you're worried again about fractures, or if you're not sure what's going on, you've obviously got to anaesthetize and then recover the horse, but there's no doubt that it gives excellent bone detail. I think it's going to teach us a lot over the coming years. Just one slide on this. So the single photon emission computed tomography images, this is a way of producing 3D images of the pelvis using certain gamma scintigraphy systems have the ability to do SPECT imaging as well. And this is just some images from this paper from Eve very recently, 2022, just to show you how you can sort of produce these sort of 3D images. This is a way of sort of offsetting some of the other tissues that you're not interested in and getting more detail on the deeper tissues without obviously the overlay of the other anatomy, of the rest of the anatomy. So on to pathologic examples. So we'll start with pelvic fractures, which are obviously fairly important and very sort of reasonably common reason for scanning the pelvis. It depends a little bit on what your caseload is. So if you have a primarily sort of sports horse caseload, then predominantly you're going to be looking at sort of traumatic monotonic fractures. If you have more of a racehorse caseload, then certainly the overwhelming majority of cases we're going to be looking at stress injuries with a smaller proportion of traumatic injuries in the younger animals, usually fillies actually, but in the younger horses. For those of you that may not have seen them, there's some post-mortem specimens here just to show you the various configurations. These are two iliac wing fractures, so pathology often bilateral in the case of iliac wing fractures, very often originate on the caudal margin and then propagate cranially across to the cranial margin. You can see that by the callus formation here, and then it's propagated forward more recently, and a coxofemoral joint fracture here. So again, we've got some callus forming here, but this is a comminuted fracture. There's obviously a fragment missing there, so that's a serious injury. Iliac wing stress fractures. So obviously when we're scanning the ilium, ultrasound would be your go-to modality. So if you were suspicious of an iliac wing stress fracture, ultrasound, trying to get this nice normal longitudinal view of the iliac wing, nice smooth sort of concave contour. Compare that with the image on the right. So this is a complete displaced iliac wing stress fracture. You can see the fragments overriding here. So these are the two extremes of what you might see, but there's obviously a whole range in between. So early injuries, sort of slight callus formation here. This is left and right. So again, always compare left to right. So we've got a small amount of callus here. So this would be the early signs of a stress injury. And really useful ultrasound is to sort of follow the callus formation along and see it mature as time goes by. So you get various sort of configurations of callus, and that can help you decide how recent the fracture is. Really useful for monitoring healing. So this is the image that I showed you a couple of slides back with the overriding fracture margins, and then 6 weeks later, same horse and a really good callus response forming there. So you can sort of check that things are coming along the right way. Just a note to say, just beware of fibrous tissue that can cause dropout, and that can make you sort of wonder why there's discontinuity of the iliac wing, but not uncommon, certainly if the horse is injured previously, to see sort of fibrous tissue within the muscle mass. This is just to remind me to tell you that healed injuries, so this is a horse that has had an injury months and months or years ago, they're often left with a sort of angle change, which is quite typical, and it's meaningless really. It's not an issue for the horse, but you can tell that this horse has previously fractured its iliac wing because of the angle change. And they also, from the external anatomy, they often get a divot just to the left of the tuber sacrale. This horse has actually also got a much more serious injury of the right side of the pelvis. So we've got profound muscle wastage on this side from a severe injury to this iliac wing, but he's also had one on this left side, and you can see that by that little divot next to the tuber sacrale on that side. They have various presentations on bone scan. So obviously bone scan is extremely useful. Ultrasound will help you pick them up. If you have a negative ultrasound, it doesn't mean you haven't got an iliac wing stress fracture. The stress fracture is obviously developed because of tensile forces on the caudal margin of the wing, and because of the bending forces on the sacrum. So they often actually very early you would see some modeling on the axial surface of the iliac wing, but that's obviously not accessible to the ultrasound. So if you have a negative scan but your horse presents as though they have a stress injury developing, it doesn't mean it's not there. So they present various sort of configurations. Most commonly would be this one here, so sort of coming from the caudal, this would be the early sign of that, so coming from the caudal border of the wing, coming slightly proximally, and then they tend to propagate cranial, as I said, towards the cranial border. This is a more sort of active injury here. This is an injury coming back into the shaft. This uptake on the caudal border, probably a sign of sort of stress remodeling because of those tensile forces I was speaking about, and this is extending back into the shaft of the ilium. Just a couple more configurations here, and just to remember that they're very often bilateral. So this has got a more serious injury on the right side, but also on the left side you can see there's a subtle lesion developing there. So that's important to detect those. They hang around for months on a bone scan. So you do have to wait an extraordinarily long period of time for them to disappear. So you don't have to wait for them to disappear before you can start training them. Again, this is a horse that fractured its iliac wing. I think it might be more than 8 months previously, but certainly 8 months or more previously, and was sound and back in training, and had trained and trained certainly significantly since this. But then went lame again on the same limb, the left hind, and the bone scan was repeated again. So we knew about this. We expected there to be some uptake in the ilium, but this horse had a distal tibial stress injury developing as well. So important if you do find something like this, and you're unsure, it's not uncommon just to screen the hind limbs as well to check that you aren't missing something else. So if you do have a positive pelvic bone scan, don't necessarily stop there. Have a quick look down below just to check there's nothing else that you need to know about. Traumatic iliac wing fractures do occur. This is a cone beam CT of a foal who had a trauma from the mare, I think, and had fractured the wing of the ilium, but also on the CT scan, it was small enough to do this in the live foal, we could see that there was also a sort of compression, sort of comminuted, quite catastrophic fracture of the wing of the sacrum. That's the S1 level here. So the CT obviously provide ultrasound, we could detect this, but the CT gave us a much better picture of what was going on axially. Iliac shaft fractures are much more serious. So they have a much greater risk really of exsanguination. So they're very close to large sort of iliac, internal iliac artery. So extremely important to know if your fracture extends into the iliac shaft. And they may or may not involve the acetabulum, and the prognosis again gets worse if they involve the acetabulum. So ultrasonographically look for sort of discontinuity of the iliac shaft and assess how that looks as it runs into the acetabulum. Per rectum, a fracture of this sort of severity, often seen with hematoma and lots of fracture fragments, and you can't really sort of miss those. Scintigraphically, they range really because they're a stress injury. You can pick them up very early if you have nice quality images. This would be completely lost on a poor quality image, or if the bladder was more rostrally, more cranially, you would lose that. But oftentimes you can pick them up on these views and quite easily detect them. This one doesn't yet seem to involve the acetabulum, but they have a risk of extending more caudally. This is an example of one of those shaft fractures that extends into the acetabulum. Sort of no recognizable normal iliac shaft on that view. Transcutaneously, you can see at the coxofemoral joint level that there's sort of discontinuity and a sort of luxation of the femoral head and the acetabular rim, and a fragment sitting here. So you can you can see quite clearly that that's going to have an acetabular involvement. The reason it's important to evaluate them and to see what the actual configuration is because it does affect management. So I won't dwell on this. This is outside the sort of scope of this lecture, but it does change how you manage them, and it does change the prognosis and the likelihood of them returning to racing. So important to get it right if you can. Traumatic acetabular fractures can occur in sort of any animal, but I've seen them not commonly, but frequently, I would say, in young thoroughbreds, again, mostly fillies, who have fractures through the growth plate in the acetabulum. So this is just a CT image of a foal to show the location of the growth plate. And acetabular fractures, they're fairly actually easy to pick up clinically when you walk in the the box, they tend to bear weight on the affected limb. They find it easy to do that. If they rest the leg, it tends to distract the fracture fragment. So you tend to walk in and think, well, hang on a minute, standing on the leg, it can't be that one. But they often do that, and very easily to detect per rectum. So this is a normal side, and then you've obviously got through the growth plate, you've got a fracture here, hematoma, hemorrhage, and very easy to detect. So this is the same horse I just showed you. So the ultrasound images were taken sort of the day or so after, always usually a history of some sort of trauma, so cast in the box or slipped over on the horse walk or something along those lines. This is 4 months later, the same filly. So now she has sort of more diffuse uptake in the right coxofemoral joint region. And this is the X-ray of the same filly at the time of the bone scan. So this is the view I was telling you about, where you sort of can raise the limb and go obliquely from the ventral aspect. And you can see the sort of callus forming here, but you can also get the impression of sort of an OA developing on the X-ray. And ultrasonographically, this is the normal left hind here, and we can see that we've got sort of more generalized sort of osteoarthritic appearance to the hip. This is that filly. She still had, at 4 months post-injury, still had some muscle wasting here. And she had a really classic walk of a horse with a hip injury, so sort of reduced caudal phase of the stride. You can probably see that's a bit lame actually on the right foot as well. But anyway, she did breed successfully, so they're not write-offs, these horses. So if you do see these, it's important to know them, to know that they can heal to sort of, you know, paddock soundness and breeding potential. In the interest of time, I'll just click on past that, and just to mention that you obviously can CT acetabular fractures. This is a post-mortem study. They do give you excellent bone detail, of course, but it's probably too late by this stage, and I'm not certain that it's going to add much more beyond your own sort of personal interest, really, because of course we're not really talking about fixing these fractures or anything, but interesting to look at them. Tuber ischium fractures are perfectly good ultrasound diagnosis, so you can again usually detect these clinically. You can see the difference between the normal side on the right here, that's the tuber ischium here, and the sort of very sort of irregular and displaced sort of bone surface here. But bone scan, really, again, we wouldn't normally get to a bone scan with those, but just occasionally they are a little bit more complicated and extend more widely into the ischium or into the pubis. So bone scan is sometimes useful, and this is a caudal view of the ischium here. You can see the two tuber ischiums there, and the dorsal view. So it doesn't really add much, but it does allow you to assess the pelvis more generally if there are usually are a traumatic injury. Pubic fractures, these they sort of represent a very small number of pelvic fractures in the horse. But they are there, and they can catch you out because they're so difficult to spot. If you've got any bladder uptake, or again, if image quality is not immaculate, you're going to miss these. So you don't see them on the regular lateral and dorsal views. Oblique view of the hip, you can see this uptake on the right-hand side here, so you can see it less intense on the left. And as it's closer to the detector, you see it more intensely on the right. Not much consensus over whether these are stress or traumatic fractures, probably a bit of both. Possibly so they sort of present sometimes like a stress injury, so it's possible that some of them have a stress component. And nice, and once you know they're fairly easy to detect ultrasonographically, but not so easy if you're not expecting one. So lumbosacral junction, sacroiliac joint, so the lumbosacral disc, again, beautiful landmark, very easy to detect, should be sort of homogeneous all the way through the disc material until you get to the dorsal ligament here. This is obviously the ventral aspect. There's a vast range of normal, really, in horses that don't have any lameness associated with this area. You often get focal sort of mineralization. You can get some sacralization of L6, S1, so sometimes you get variable amounts of disc material. Some abnormal findings, so this has got a more profound area causing a sort of reverberation artifact here. Sort of, you can imagine that there is some protrusion of the disc base. To decide if there's any sort of herniation, which is rare actually, but if you sort of draw a line, a sort of imaginary curved line between the two bone surfaces, if it goes out with that line, as this one does quite considerably, we've got some sort of protrusion here, then you can sort of be fairly confident that it is protruding. Just remind me to say that you do sometimes get sacralization at L6S1 and transposition of that, which isn't the case here, and transposition of the disc space at the L5, L6 level. So if you've got a sacralized lumbosacral junction, just go slightly further forward and check you don't have any pathology in the disc space at L5, L6. And this is the intertransverse joint. So intertransverse joint, just to remind you of the normal. So there's the normal joints, nerve root fossa and nerve root exiting. And this is an example of a horse with a remodeled intertransverse joint. So you'll see possibly a little bit of fragmentation here. Same signs that we look for on all joints when we're talking about sort of OA or remodeling changes. So irregular margins, fragmentation, lytic areas, this sort of thing. So they have the whole gamut of that type of lesion. However, the range of normal is wide, so it is difficult to know the significance of some of the findings. This is a CT case, which was a post-mortem case. This horse presented with a strange hind limb gait, which we don't really know if it was related to what we eventually found because we couldn't block it at the time. But on the CT of the pelvis, this is just to orientate you. So L6S1, and this is the intertransverse joint here, and we've got some bone spurs sort of projecting axially into the S1 nerve root fossa. You can see that better on the 2D image. So, you know, this is not something that we're going to find commonly in clinical cases because we won't get the opportunity to look, but just do bear these things in mind if you have an unusual case. SIJ remodeling, ultrasound, relatively normal joint here, widened joint space here, new bone formation, and this type of thing. So again, looking for asymmetry in the joint rather than just simply remodeling changes. Bone scan. So we've, again, the dorsal view is perhaps the most useful. It tends to get a little bit lost on the oblique views, and the uptake sort of, obviously you've got your tubus sacrale here, so we're looking at the sort of abaxial aspects of the tubus sacrale for uptake in those regions. And again, we are primarily looking for asymmetry, so uptake such as this, so a little bit of tiny bit of uptake in that region in a nice image on a horse with not too much muscle mass could well be within normal limits. So don't just look for uptake, but look for asymmetry if you want to be more sure that this is something of interest. Obviously, you can do lots of post-processing and analysis on these. So profile analysis, just looking at not necessarily the sort of the amount of uptake there, but rather the profile of it. So how wide and if there is any asymmetry. So you can see that there's a sort of wider shoulder on the profile of this side. These are from the Dyson paper of 2003, both normal horses without any evidence of pelvic pain, a 2-year-old thoroughbred on the left and a 12-year-old warm blood on the right. So there are sort of age-related differences to the appearance of these joints on scintigraphy over time. So it's important to make sure you know the age of the horse if you're interpreting the images, and also don't compare it in your head to younger horses. Make sure you compare it to age cohorts. Quantitative analysis, so regions of interest, again, it is described. It's technically somewhat flawed and it's not something that I particularly do in clinical practice. Again, it's useful perhaps to be able to do sort of objective analysis, but how applicable it is to the management of the case is perhaps somewhat questionable. CT, this is just an image of post-mortem images. You can see there's no soft tissues to show this was a horse without evidence of any pelvic pain. Just the difference in the symmetry of these joints, so much wider. If you're ultrasound scanning this, a much wider joint space here compared to here, and there's remodeling on the axial surface which you would not see ultrasonographically. And again, reasonable amounts of change here actually, but not a lame horse. And this again, just to show that a lot of the action might be going in outside of what you can detect ultrasonographically. So this might look relatively normal if you were looking at it per rectum, but probably would have some uptake on the bone scan, but difficult to know. So I just included this slide just as something of interest. So this is a CT A CT is quite good for sort of throwing up things that you perhaps weren't expecting, or sort of X-file conditions that might be something that wasn't on the radar. And this is a sort of a discospondylitis in a weanling. So it is a clinical case. So this horse was live. This is a fan beam CT. So the image quality is about average for what you would expect. And you can see that this horse has got discospondylitis at that level. Not impossible to detect radiographically, but obviously it would need a sort of a GA or certainly a recumbent X-ray to do that. And the CT obviously gives you just such amazing detail. It's certainly rewarding when you do get the chance to do those in clinical cases. So conscious of time, sorry, but ultrasound, so conclusion, why ultrasound is the mainstay of pelvic injury diagnosis, and it has replaced X-ray in most scenarios. So most people would go for an ultrasound and perhaps leave the X-ray unless they're particularly restricted on access to bone scan. Improved accuracy in combination with bone scan. So certainly in some of the sort of degenerative conditions of the sacroiliac joint region, you're very unlikely to have a nailed on positive diagnosis on the ultrasound. You will have to combine it with another modality, and that's usually bone scan, and certainly needs to be correlated with the clinical presentation and sort of the results of other diagnostic imaging and clinical findings. It's usually sort of presumptive diagnosis imaging wise rather than definitive. CT and SPECT are sort of rarely used in clinical practice still, and they probably will remain so for quite some time. You just sort of can't change the physics of it to a certain degree, but likely to yield a more complex information on more complex injuries going forward. Okay, so I'm going to just left to thank Rob, Marcus and Pete, who provided some of the images in this presentation, but also have been mentors, colleagues and collaborators of mine over the years, and I don't know what I would have done without them, quite frankly. So that's it. Leave you with some information about us on the final slide.
Thank you very much for that, Lucy and Sarah. So we've got a bit of time for a question and answer session now. So I hope you all enjoyed it. Please pop any questions that you've got into the Q&A box at the bottom of the screen.
Okay. I can't see any questions at the moment, but I did have a question for Sarah. What would be your clinical indication for doing ultrasonography of the lumbosacral joint? Would it be based on scintigraphic findings, or?
It depends a little bit. So very commonly, obviously, horses coming in for poor performance workup. So nondescript findings, poor hind limb propulsion, bucking after jumping, these sorts of things. So certainly it would be routine in those sort of slightly complex nebulous cases where may have back pain, may have pelvic pain, may have low-grade bilateral hind limb pain. You're sort of doing it as a rule out, really, to make sure that you've ticked all the boxes. And then obviously if you're not expecting it and find some uptake in the SIJ region on a bone scan, then again the following day or 48 hours later, depending on your local rules, an ultrasound scan, just to sort of more sort of thoroughly assess what the uptake on the bone scan was indicating. But yeah, most likely it will be in the show jumpers and the dressage horses that are coming in with sort of performance issues.
Cool. Good, thank you. That answers the question very well. Maybe I should start doing more of that as well. I only tend to if there's scintigraphic uptake. So.
Too much of my life with my arm in that area. But you have to do a lot of them in order to know what normal is, or what the range of normals is. Then there's no substitute for just putting your hand in everything that's standing in the stocks if they'll allow you to do it. So
yeah, I thought I'd escape that not being a repro vet, but looks like it's new direction.
Yeah.
And the other question I had was, if people are suspecting a pelvic fracture, is there any value to trying radiographing in the field with a portable generator, or would that be a likely pointless task?
Pretty pointless. I mean, I think you need a sort of higher power generator in order to get something meaningful. I mean, it depends a little bit on the size of the horse and muscle wastage, which sort of kicks in perhaps 10 to 14 days after injury. If you get the muscle really dropping off and you've got a small animal, then it's certainly worth a try. If your access to other things are restricted, or if you don't want to move the horse for for safety reasons, then it's worth it. But I think generally speaking, it's underwhelming to do it's underwhelming to do when you've got a gantry generator and everything's all set up for it. Most successfully you would do it in a horse that wouldn't weigh more than about 500 kilos, so perfect for thoroughbred practice, not so great for anything larger than that, unfortunately. If we're talking about more superficial injuries, so tubercoxa, third trochanter of the femur, tubericium maybe, then that's worth a try. But again, with a tubercoxa fracture, if it's displaced and you're going to detect it clinically, if your head is screwed on right that day, then you're going to see something clinically that's going to make you decide that that's probably what it is. So and then your ultrasound will confirm that that's what you have. So the fractures that you can possibly x-ray in the field, you probably don't need to, because you've diagnosed it clinically with ultrasound. So it's a bit of
so reach the ultrasound machine rather than your x-ray machine.
Yeah.
You've got such things in your car.
Yeah, exactly.
Perfect. I can't see any open questions, so I wonder if maybe we leave it there.
Yeah, it doesn't look like there's any that have appeared, but if anyone thinks of any, you can feel free to drop us an email. We'll be delighted to answer them for you. So hope you've enjoyed, and there'll be a follow-up link that we'll send out to all of you, so you can rewatch and also share it with any of your colleagues. But great to see you all. Thank you so much, Sarah and Lucy, and I hope you all have a good rest of your day.
Thanks, guys.
Bye-bye.
Bye, everyone.